Very good afternoon to all of you. I would like to invite Dr. Venugopal Kulakarni. He is my close friend also. We did Anaesthesia together at MMC Medical College. He is alumni of MMC Medical College. He has done PDCC in cardiac anesthesia from Amrita Institute of Medical Science Coaching, FRCA from UK. And then his special interests are physiology and physics, ultrasound applications in anesthesia, patient safety, and his achievements are he is a gold medalist in TEE accreditation exams. Now he is currently heading the Department of Anesthesia at Yashoda Hospital, High Tech City, Hyderabad, and he is the President-elect of ISS City Branch, Hyderabad. Over to you, Dr. Venugopal Kulakarni.
Thank you very much for the introduction. And I first of all thank the organizers, especially Dr. Usha Madam, for inviting me for this conference. I'll be talking on this perception and practice of depth of anesthesia monitoring. How do anesthetists perceive this depth of anesthesia monitoring, whether we should do the monitoring, is it required, is it mandatory or not, and whether they really implement that in the practice. So before going into that, I'll just talk on what is the problem statement. So when we give anesthesia, you know, there are various stages of anesthesia, and various, like we anesthetize for sedation, and we anesthetize patient for complete anesthesia, and also if the anesthesia goes deep, there will be hemodynamic changes. That is the direction in which anesthesia progresses. And after anesthesia, awareness. When you interview the patient, some patients will tell that they had awareness, and then it is rare, about 0.18%, but it is a serious problem. And when after listening to Shivakumar, I don't think so. These are serious problems in that context. Yes, but yes, they are serious problems. There were legal issues, and there were a lot of media reports and then media hypes regarding awareness. And various types like unable to move, auditory sensations, anxious, fearful, panicness, pain, and burning and tactile sensations were some of the reported problems. Okay, there was one study in rural India. There was a single center study. They interviewed with the modified price questionnaire, 896 patients. 7 patients had reported about, but there are only 3 confirmed cases of awareness, which the incidence comes to 0.33%. So this is the price questionnaire. What do you remember before anesthesia? What do you remember after waking up? And do you remember anything between going under anesthesia and waking up? Do you dream? Did you dream before, after, during your procedure? And what is the worst thing about your operation? So this price questionnaire, if you ask, even this there is no explicit recall, but they may answer your questions, and then where you can confirm whether they had awareness or not. And the consequences of awareness are like the risk of anxiety disorders. People can develop 80% in the first 3 weeks. 50% of them remain at risk of developing anxiety disorder for the next 2 years. There can be long-term psychological sequelae, and they fulfill the criteria of post-traumatic stress disorders. And again, medical legal claims, 2% of them. So there will be consequences for the anesthetists also. So we have to be careful. So there is one more Michigan awareness classification, which is just like again, auditory perceptions, tactile perceptions, pain and paralysis. There are risk factors for awareness. There are major risks, minor risks. I'm just running it through fast because we have to see what is our perceptions regarding monitoring of awareness. And then there is one publication that came in the BJ in 2015 about intraoperative awareness, controversies and non-controversies. So on the left side, on the left side here, this is for those patients who are undergoing sedation. On the right side is for the patients who are actually undergoing general anesthesia. So you see the circles. This is the unintended complete general anesthesia here, but you want all the patients to be aware without recall. That's the green one. The orange one is where patient will have expected awareness with recall, and unexpected awareness with recall will be a small portion of that. So whereas in general anesthesia, intended general anesthesia is more, and awareness without recall and awareness with recall is a small portion. And there are there can be various complications because of that, and they club them into whether controversial and non-controversial. One is that whether there can be psychological sequelae in those patients having awareness without recall, in patients undergoing general anesthesia, whether patients undergoing sedation can have post-traumatic stress disorder-like symptoms in susceptible patients, whether there is any genetic component, again it's a controversial thing. So this is a nice article which we can go through. And then monitoring the depth of anesthesia, just wanted to give a perspective of what are the available things. So subjective methods like which we normally do, autonomic response, that we see the hemodynamic changes, sweating, lacrimation, and isolate forearm technique and clinical things. Objective methods are there. This isolate forearm technique where we isolate the forearm, we can tie the BP apparatus here on this arm, and the downstream we can tie the tourniquet when we give the relaxant so that the fingers are not paralyzed. And then when we give a communication when we communicate with the patient, they can obey the command. And if you ask them to move the fingers, we know that whether they are awake or not. And then whenever you are giving a top dose of relaxant, we should ensure that the tourniquet is inflated. And then processed ECG, we know that with anesthesia there are changes in the ECG, and then with the increasing depth of anesthesia, the ECG becomes more and more, the amplitude increases, it becomes slower, and then finally there is isoelectric line. And then power spectrum also changes. So power is like the square of the voltage, and then so as the depth of anesthesia increases, they become less, the frequency reduces, whereas the amplitude increases, the power increases. So this is where this graph shows about what happens to the power spectrum with changing the depth of anesthesia with 0.3% to 1.1% of isoflurane. And then the beta ratio also changes. And then these various things like time domain, the power domain, the frequency domains are analyzed so that we can get a processed ECG. And there are EEG based monitors are there, like BIS monitor is there, which is most common. And then we have entropy, narcotrend, and cerebral state monitor, patient state index is there. So there are various things are available in the market, but yeah, I mean, if there are various monitors, it means that not one is a gold standard, okay. And usually when the processed EEG monitor, we monitor from the forehead surface electrodes, and then EEG is then processed. And then what we have to see is that propofol, thiopentol, and all volatile anesthetic agents, they produce a similar pattern of EEG, whereas it is different for ketamine, nitrous oxide, and xenon. Again, this variability is there when we are monitoring the EEG. And initially there is a high frequency components increase, and then the proportion of low frequency EEG components increases, and there is an increase in the amplitude with the deepening of anesthesia, and there is increased regularity, because initially when the patient is awake it's all irregular, and then becomes more regular, then finally bursts some pressure, and then the complete isoelectric line is there. And then these things, these various parameters are clubbed together, and they have algorithms, and then they are built in, and finally we are given one number. So that is what BIS does. So nobody knows, that's a commercial secret, so it is not yet revealed, it is elusive. So we just get a number. So we about 40 or something BIS, we are happy that the patient is anesthetized properly. And then narcotrend, again there is numbers, and then they say that narcotrend differentiates between EMG and EEG better, and then so that we can make a differentiation. That differentiation is not there in the BIS. Again, it classifies into various 6 classifications, and then there are again 15 substages are there. And then what we have to achieve is the D and E stages where it is surgical anesthesia. And then finally these are all indexed 0 to 100, and then it is and then entropy is there. So do we use all these things? That's the question. Is there a need for using them? Do we need to use it in the practice? So in 2004 there was a survey in UK. So they had 26 questions in 285 hospitals, 4,900 consults were sent these questions. 44% was the response rate, and these are the things, some of the things. Do you think awareness is a major problem? Okay, so from 0 to 10, okay, so they say 2 and 3 are the maximum number. 2,000 responded, so 1,000 of them, 1,000 people, nearly 50% of them said it's not like on the severity scale, it's 2 and 3 is the importance of anesthesia. I mean, awareness is given by the anesthetist. And do you think awareness should be used for all cases of general anesthesia, all cases of where relaxant is used, only for high risk cases, if the patient has had an episode of awareness in the past, and then if the patient specifically requested for an awareness monitor. So many of them said that it's high risk or there's a previous episode. And again, see, I mean, whether it has to be used, how often do you use? So some people, only few people said always, usually, sometimes and never. So majority of them fall in this sometimes and never. Okay. And 56% in 2004 said that they have not used depth of anesthesia monitor. Okay. And do you routinely use? Only 89 people of both those who responded said that they routinely use. 95.7% said that they don't routinely use depth of anesthesia monitor. And do you delegate or do you ask after the anesthesia? Do you ask the patient going and ask that price questionnaire where you recall regarding recall any questionnaire? Now only 92.9% did not ask those questionnaire. Do anybody of you ask questions to the patients whether they had any problems like regarding awareness during anesthesia after surgery? How many of us will ask? Can you raise hands? Do you ask them routinely?
So we have a study. We are doing it in ERCP procedures. For that we do conduct sedation.
Okay.
So we do ask for awareness.
But it is sedation. You expect them to be like conscious sedation. You expect them to recall, isn't it?
Conscious sedation, but we use two different combinations to know the awareness in both the combinations.
Okay. Do you intubate them? No. For ERCP we don't intubate. Okay. Okay. And then again this went on, and then they did one more like survey in like 2011. I think there were problems in the UK regarding awareness, so they did again, and then 329 hospitals, 7,125 anesthetists. This time the response rate was better, from 44% to 82%. So there were 153 new cases of accidental awareness were notified, and then the estimated incidence was 1 in 15,414. So timing of awareness, so the thing is, we have to notice the timing of awareness in these things were 47% is after induction and before the start of surgery, only 30% was during surgery, and 35%, 23% was after the surgery is finished and before extubation. So this is where like we sometimes give anesthesia the patient, we will not put the inhalation agent when you are mask ventilating, or our player of anesthesia will be lighter before they put the incision, and then after like after the surgery is finished, we reverse the patient, but we would have like switched off the isoflurane or like what inhalation agents, but we give reversal at the end. So that's where the patients can have awareness. So we have to be careful about that. But again, the response was that only 1.8% of the anesthetists were routinely use the depth of anesthesia monitor. There was a NAP 5 handbook came in 2019 based on the survey, and there was a guidance, and all patients should be informed about the risk of awareness during anesthesia. Shall I take one more minute? Yeah. And when consenting the patient, you have to explain them the risk of awareness, and consent for sedation should emphasize that they will have recall, because that is what sedation we have to. They should be able to recall. They should be able to respond to us during conscious sedation, and then there were recommendations in. If you see the recommendations for monitoring in 2021, what came? So I just highlighted. Neuromuscular monitoring is essential and should be used. Okay. Every operating theatre should be equipped with the neuromuscular whenever there is for the quantitative monitoring. So this is regarding neuromuscular monitoring. And what is the recommendations for depth of anesthesia monitoring? May aid, may reduce, and processed EEG monitoring should be used when TY is administered together with neuromuscular blockade, and should be considered when TY used alone. So only when TY used along with neuromuscular blockade and along with this thing, the recommendations are should be. Otherwise, it is may use, may use. So how many of us will use it if the recommendations are maybe? Okay. So there was a recent study in 2022 in Jordan. So where they interviewed 107 anesthesiologists who participated, and 34% said that they have never used a DOM, deep depth of anesthesia monitor, and 6.8% use depth of anesthesia monitor in daily practice. But 81.3% said that they believe that depth of anesthesia monitor are effective. So 35% have not even seen probably the depth of anesthesia monitor. So they see that they are very effective, and the value is their accuracy, and they say cost effective. Purpose of using. So the purpose of using is to prevent awareness and guiding the delivery of anesthetics and reducing the recovery time. This is what they thought the use of depth of anesthesia monitoring. And then the most used is BIS, and then they also think that BIS is the most accurate because that is what many of us have the experience with. This is the BIS monitor only. And most of them said that whether only number is important or EEG trace is important, they all believe that all the three should be taken into consideration. And always use is only 7, and then 1/3, 2/3 were like 13, and 72 people responded that only less than 1/3 of their cases they use, and then never uses 15. So, in conclusion, our usage of depth of anesthesia monitoring will also depend on our availability, and depth of anesthesia monitor are not widely available. They are not widely available because we have to see the utility of it. And Dr. Basuraj is here. I should ask him whether he will be investing money to buy a depth of anesthesia monitoring in his hospital. So he will calculate what is the return of investment. So that is what many hospitals they do. What is the return of investment for this? So availability is a problem because of what is the return of investment they will see. And then we have to not make them available because it's not mandatory. This guidelines also they say may use, and it adds to the cost. And many of us they don't ask that questionnaire whether because awareness is difficult to prove and more difficult to disprove. And the recommendations from the association are to be more assertive on neurovascular monitoring than awareness monitoring. And there are many methods because there is no gold standard. Thank you.
Thank you, Dr. Venugopal, for the wonderful